Welcome to JADEL TV. This is Vince Sorrell, and I'm going over again another video that was on my Twitter feed that received greater than 50 likes. It's had a very long discussion from multiple people, and I thought it was worth going ahead and bringing it over to my JADEL TV channel. As you can see, I showed the long axis view of a parasternal long axis, and in doing so, there's a couple of things that I'll go ahead and try to point out here. In this particular case, I think everybody was struck by the fact that the aortic root looked big. And for novice echocardiographers, the aortic root is typically about the same size of the left atrium. So when you see an aortic root that's twice the size of the left atrium, that's a clear marker of dilatation. There's also centimeter markers over here, and you can see that this exceeds 4 centimeters, making this a dilated aorta, regardless of how big the patient is or what method you use to index the aortic root. The other feature that I'll try to point out is the aortic valve. And as we come into systole, a lot of people picked up on the point that there was this curvature at maximal systole, and this is a typical finding of a congenital valve. At this point, you're predicting that it's probably a bicuspid valve, being the most common type of congenital abnormality occurring in 1% of the population. But it's also possible that any congenital valve, unicuspid valve, or even possibly a quadricuspid valve, could have doming in systole, and it's going to force you to look at this in a short axis view. If I go ahead and let this play, I swept over to the short axis view, which gives the answer here. And very nicely now you can recognize that you've got a three sinuses of Valsalva, a leaflet that at this point you're not sure if it's going to be a bicuspid valve or a trileaflet valve. And then as systole, when the leaflet's open, you realize that you have a raphe here, which is separating the two leaflets, making this a rather conventional type of bicuspid valve. So you have the fusion of the right and left and right valve leaflets, the non-coronary cusp over here, which straddles the interatrial septum. And that's a good way to remember where the non-coronary cusp is. It always straddles this interatrial septum. And then the raphe can be seen right in this region here. So some of the comments that people made included this possibly as a type 0 or a type 1 valve. And there are different types of classifications of aortic valves, and I'll try to show you quickly what they look like. Everybody recognized that the association between a bicuspid valve and aortic dilatation. Some people questioned if this was a dissection, but this actually represents a side-lobe artifact. And there's a number of features that tell you that that's artifact and not real. But if you wanted to be sure, you can put color on here, put contrast in here, look at it in different depths and different angles. A couple of people weren't sure if this was a true bicuspid valve or if this was just off-axis with possibly angulation artifact, and it's always a good thought. And anytime you only see one view, it's always wise to ask for more views. But in these little Twitter images, we usually just show one view. Other people were questioning whether this represents dilatation or an aneurysm, and the definition of those should be consistent in your lab. And typically by radiology, we just look for a 50% dilation greater than the normal range, and that would represent an aneurysm. And then finally, somebody did make a comment that they thought this might represent a Notch 1 mutation. A Notch 1 mutation this is a transcription gene that's important in signaling pathways. It's critical in the development of the aortic valve and the aortic root. And certainly it's something that you want to consider. It's a cause for non-syndromic abnormality of the aortic root and can lead to premature calcification of the aortic valve as well. So I did want to Also, just quickly go over the Seaver classification. This was from a paper in the Journal of Cardiothoracic Surgery, published in 2007, and they very nicely describe type 0, type 1, and type 2. The way to remember this is it's the number of commissures. So type 0 has no raphe that can be seen. Type 1 has one raphe, which was what we saw in this patient. And then type 2 actually has two raphe. You could also further subcategorize these based on the left and right involvement of what is fused. And like I said, this is not the only classification that exists. There are many other classifications. I used to always use this classification, which was relatively simple, and you can think of it as having either equal or unequal involvement of the leaflets and involving right or left versus non-coronary cusps. But again, just have a classification that you're comfortable with and you use consistently across your reading group, and try to be consistent in the language that you report it. It's always also safe to just describe what you see, and I appreciate your time. I hope this was somewhat meaningful. Have a good day.